Hello, my name is Stacy Irvin. I am a nurse practitioner student at the University of Texas, Rio Grande Valley, and I am doing a schizophrenia case study evaluation. Case study number 3, Gregory Baker. Gregory Baker was a 20-year-old African-American man who was brought to the emergency room by campus police of the university from which he had been suspended several months earlier. The police had been called by a professor who reported Mr. Baker walked into his classroom shouting, "I am the Joker, and I am looking for Batman." When Mr. Baker refused to leave the class, the professor contacted security. Mr. Baker was previously a well-functioning and very successful in school. He suddenly became withdrawn from his friends and social functions, spending time alone mostly. He stopped talking to family and was suspended to school due to absence. No previous psych care or hospitalizations in his history. His grandmother died in a state psych hospital after 30 years with an unknown diagnosis. Case study continued. Mr. Baker was well-groomed, generally uncooperative. Constricted, guarded, inattentive, and preoccupied. He became enraged when the ER staff brought him dinner. He believed the hospital food was poisoned. He exhibited paranoid, grandiose, and romantic delusions. He appeared to be internally preoccupied, although he denied any hallucinations. Symptoms and behavioral history are consistent with schizophrenia. Diagnosis and rationale. Mr. Gregory Baker has schizophrenia, first episode, acute phase. Highly functioning with sudden decline. He has paranoid, grandiose, and romantic delusions. He responds to internal stimuli, auditory hallucinations. Negative symptoms are present, lying in bed all day, and symptoms have persisted and intensified over the last year, greater than a 6-month duration. Description. Schizophrenia is a mental and psychiatric disorder that causes individuals to interpret reality abnormally. Delusions, hallucinations, and extremely disordered behavior and thinking. Diminish of the daily functioning. Early treatment may allow the symptoms to be contained and avoid serious complications. Manifestations. Cognitive, emotional, and behavioral problems. Varied, but usually include disorganized speech, thinking, delusions, hallucinations, extremely disordered and abnormal motor behavior, and negative symptoms. Delusions refer to false beliefs that conflict with or are not founded. May issue answers that are either wholly or partly unrelated to the questions asked, and their speech may include meaningless and unintelligible words. Possible childlike silliness, unpredictable agitation, resistance to instructions, bizarre posture, and useless movements. Neglect of personal hygiene and loss of interest in everyday activities. Manifestation differences in teens. It's more challenging to diagnose in teenagers. It's common with the developmental features during the teen years. There may be a noted decline in school performance, trouble sleeping, lack of motivation, withdrawal from family and friends, and a depressed mood. Can be possibly mistaken for recreational substances such as marijuana and methamphetamines. Teenagers may not exhibit symptoms of delusions and are highly likely to experience hallucinations. Causes. Genetics and the environment are key contributors. Possibly brain neurotransmitters known as glutamate and dopamine contribute. Neuroimaging studies reveal that CNS and brain structure of individuals with schizophrenia are different from those without the disease. Risk factors. Family history of schizophrenia. Pregnancy and birth complications, such as exposure to viruses, toxins, and malnutrition that could compromise a child's brain development. Use of psychoactive and psychotropic drugs, especially during the teenage years and early adulthood. Complications. Depression, social isolation, medical and health problems, abuse of psychoactive and psychotropic drugs, obsessive-compulsive disorder, anxiety disorder, suicidality, homelessness, financial difficulties and homelessness, inability to attend school or work, being victimized, developing aggressive behavior. Treatment. Psychological therapy and psychosocial interventions with pharmacological treatment. Second generation atypical antipsychotics, except for clozapine, are the agents of choice for first-line treatment of schizophrenia. First-generation antipsychotics have a greater risk of extrapyramidal symptoms. Cognitive behavioral therapy and family interventions have been successful in managing and improving the coping strategies. Pharmacology is first line in schizophrenia treatment. Act on the neurotransmitters present in the brain. Help with complications such as delusions, hallucinations, and thought disorders. More effective in managing the disease positive effects than its adverse effects. Most individuals report significant improvements. Injectable medications lead to reported significant cognitive function improvements such as attention, memory, and verbal learning. Practice change. Schizophrenia is one of the psychiatric and mental conditions that affect the wellness of a significant number of persons. The condition thus falls within the realm of my psychiatric practice. Combined pharmacological and therapeutic interventions are necessary. Compliance can be an issue. Long-acting injectable medications improve compliance and outcomes.